Screen. Sorry, 1 second. Okay, can you see my screen?
Oh,
Yes.
Okay. All right, so we're going to be talking about perioperative nursing. So perioperative nursing consists of preoperative nursing, intraoperative phase, and the postoperative phase as well. So we're first going to begin with the preoperative nursing management. So I'm just going to go over the 3 phases and what they consist of. So the preoperative phase is before surgery. So it's when the patient agrees to the surgical intervention, and it ends when the patient is onto that OR bed. The intraoperative phase begins when the patient is on the OR bed and ends with an admission to the PACU, which stands for the post-anesthesia care unit. And then the post-operative phase begins with the admission of the patient to the post-anesthesia care unit and ends with a follow-up evaluation in the clinical setting or home. Okay, so we're just going to go into preoperative. So the decision to perform surgery may be based on a diagnosis. So sometimes they do surgery if they want to diagnose someone with something. Someone presents with a lot of symptoms and they want to diagnose them with something. Maybe they have a lump, so they want to do a biopsy. They also do surgery as a cure. If someone has a tumor, they need to get excised or removed, or even like an inflamed appendix to get that removed as well, or to repair something. Surgery can also be reconstructive or cosmetic or palliative to relieve pain or correct a problem. In addition, surgery might be rehabilitative, such as a total joint replacement. And then surgery can also be classified based upon the degree of urgency involved. I remember this from my quiz last year, so she might ask a question like this if you have, Remy. Maybe just pay attention to this. So emergent, the patient requires immediate attention. Disorder may be life-threatening, so that surgery has to be without delay. Urgent is telling me that this patient requires prompt attention, so they're going to need surgery within 24 to 30 hours. It's not emergent or they need it right away, but they are going to need it soon. Required surgery is that the patient needs to have the surgery. It can happen within a couple weeks or months. And then elective is that the patient should have the surgery, but failure to have the surgery is not catastrophic and the patient won't die. And then optional would be like a cosmetic surgery. Yeah. All right. So pre-admission testing and preoperative preparation prior to admission reduces hospital stays and reduces costs. So they usually do pre-admission testing before the patient even, comes to the hospital for the day of the surgery. So they do this, so they don't waste a lot of time and things like that, and the patient knows what to expect. So they focus on admission data such as patient demographics, health history, and other information pertinent to the surgical procedure. So they talk about consent forms, diagnostic and laboratory tests. They may need to get like blood work before surgery and things like that. So it's a bit of preparation before the day of surgery. During the pre-admission visit, patients learn what to expect on the day of surgery and receive answers to questions they may have. Nurses in this pre-admission testing department are responsible for communicating information related to the surgical procedure and the effect that the surgical procedure and the anesthetic may have on the patient's health status, functional status, and family dynamics. When I talk about family dynamics, is that in an anesthetic medication, a patient can't just leave after receiving anesthesia. They're going to need a family member to come in and sign them out. Any questions so far? Okay. Gerontological considerations, so that means older adults. Older adults' cardiac reserves are lower. The older adult is at higher risk of cardiovascular complications. Of all the body systems, the cardiovascular system exerts the most influence on anesthesia. So always pay attention on that with them. The older adult patient usually has decreased or slow circulation to the rest of the body. A preoperative assessment includes blood tests, blood pressure, EKG, and identify potential risk, including anemia, which means low red blood cells, hypertension, and arrhythmias. Renal and hepatic functions are also depressed with older adults. GI activity is likely to be reduced, respiratory compromise, and decreased subcutaneous fat. So they're more susceptible to temperature changes as well as pressure ulcers. So we pay attention to pressure ulcers, and we want to think about that if they are having like a very long surgery as well. We may need more time and multiple education formats to understand and retain what is communicated. So with older adults, you just want to take more time in explaining things to them because they may have poor concentration, confusion, or disorganized thought patterns. So therefore, a comprehensive assessment that focuses on cardiovascular, respiratory, renal systems may help improve immediate perioperative outcomes. So with any patient, we do want to do a comprehensive assessment and just focus on all the body systems. In terms of bariatric considerations, so these are obese patients. Preoperative assessment of the patient with obesity should pay careful attention to pulmonary, cardiovascular, psychological, and integumentary systems. So again, like we're going to do all our checks with patients, all of the body systems, which we'll get into a little bit later. This is really important. Required preoperative documents. So informed consent is the most important one. It's the patient's autonomous decision about whether to undergo a surgical procedure. It is voluntary and written informed consent from the patient is necessary before non-emergent surgery and can be performed to protect the patient from unsanctioned surgery and protect the surgeon from claims of an unauthorized operation or battery. So consent is a legal mandate, but it also helps the patient to prepare for the surgery because it helps to ensure that the patient understands the surgery to be performed. It is the surgeon's and anesthesiologist's responsibility to provide a clear and simple explanation of what the surgery will entail prior to the patient giving consent. The surgeon must also inform the patient of the benefits, alternatives, possible risks, complications, and all things like that. So yeah, you as the nurse, you want to make sure that that surgeon and anesthesiologist come in and they explain all these things. And then you're going to give the patient the forms and you have to watch them sign the forms before giving them a medication. So usually we give a patient a psychoactive pre-medication prior to surgery. An example is a benzodiazepine. You probably haven't learned about it yet, so don't worry about this medication too much, but it's just an example. So a benzodiazepine is a muscle relaxant. It also helps patients with anxiety, and it also can help a patient like fall asleep. So that medication can just relieve some nerves and things like that. So you want to make sure that they sign consent forms before you as the nurse give them a pre-medication before they go to surgery and get that anesthesia. Okay, so the key takeaway is that no patient should be urged or coerced to give informed consent. Refusing to undergo a surgical procedure is the person's legal right and privilege. Does anyone have any questions?
No.
Okay. So the preoperative assessment, so every attempt is made to assess for and address risk factors that may contribute to postoperative complications and delay recovery. So you're always going to want to do a health history. Are there any underlying conditions that may affect the patient's response to surgery, techniques, and anesthesia? Do they have cardiac failure? Do they have hypovolemia, which means do they have low fluid in the body? Do they have any electrolyte imbalances? Do they have cirrhosis, which is scarring of the liver? Anything like that you would want to just note. And then as the nurse, you're going to do physical exam of all body systems. And then you're also going to pay attention to medications that they're currently taking, as well as any allergies they may have. So you want to ask the patient about the use of prescription and over-the-counter medications, including herbal and other supplements. So these are a couple of medications that can potentially affect the surgical experience. I saw this in your PowerPoint, so I just wrote out like what these medications are. You probably haven't learned about them yet, but if you have Remy, she usually will give you an outline saying like what medications you should know, but these are just a little bit about them. So corticosteroids are medications that decrease inflammation. We see corticosteroids when a patient has asthma. So asthma has a lot of inflammation in the airway. So we use corticosteroids to decrease airway inflammation. Diuretics are your medications you give to patients who have a hypertension, or patients who have edema, so fluid in the legs. Diuretics make patients void, and if this patient is like voiding a lot, they can this medication can cause hypotension as well. Phenothiazine is used to treat a variety of mental health and physical conditions. Tranquilizers, they have a calming effect. They reduce stress and treat anxiety and insomnia. Insulin, patients like this who have diabetes, and insulin helps lower sugar levels. Antibiotics treats infections, and then you have anticoagulants, which prevent your deep vein thrombosis, venous thromboembolism, and pulmonary embolisms. Anticonvulsant medications are the seizure medications. Thyroid hormones, this medication helps patients with low thyroid levels. And then you want to know if they're on opioids. These are medications that help treat moderate to severe pain. And then you want to pay attention to those over-the-counter and herbal medications they may take. So this is just a list of medications that can affect the surgical experience. But if you have Remy, she probably will tell you which medications to like pay attention to. And then you want to know if they have any known allergies. Does anyone have any questions about these?
No.
And then nutritional status. So optimal nutrition is an essential factor in promoting healing and resisting infection. Fluid status. So assessment of a patient's hydration status is also essential. Preoperative fasting helps prevent the risk of aspiration. So aspiration is when, a patient doesn't swallow the right way and then fluid goes into the airway. And then aspiration is a big risk because it can cause pneumonia, which is an infection of the lungs. So yeah, we want to prevent aspiration. So that's usually why patients aren't on liquids before surgery. Dentition, the condition of the mouth is an important health factor to assess. So you want to know if this patient has any dental caries, dentures, and partial plates, because they're particularly significant to the anesthesiologist or the CRNA, because decayed teeth or dental prosthesis may become dislodged during intubation and occlude the airway. So you just want to know if they have any like fake teeth or any dentures, because if they're wearing that during surgery and you didn't know that they had it and it includes the airway, that could happen. This is important for older patients as well as those who may not have regular dental care. The condition of the mouth is also important because any bodily infection, even in the mouth, can be a source of a post-operative infection. So even like looking inside the mouth as well is really important. So drug or alcohol use. So excessive alcohol consumption can cause arrhythmias, infections, and withdrawal. These factors can lead to extended hospital stays and increased complications. The use of illicit drugs and alcohol may impede the effectiveness of some medications. You also want to check their respiratory status. So the patient is educated about breathing exercises and the use of an incentive spirometer. So an incentive spirometer, patients usually use this before surgery and after surgery as well. Patients like breathe into it because it helps like expand the alveoli, that little sacs in the lungs that are responsible for gas exchange. So it helps expand those alveoli, just to make sure that the lungs are working well. In a insensitive spirometer, helps exercise the alveoli. Patients with underlying respiratory diseases, you want to know if they have asthma or COPD. They are assessed carefully for current threats to their pulmonary status. Okay. Patients who smoke are more likely to experience poor wound healing, a higher incidence of surgical site infection, and complications that include venous thromboembolism and pneumonia. So during that preoperative assessment, patients should be asked about current and previous tobacco use. The preoperative visit isn't an optimal time to advocate for smoking cessation. Patients undergoing elective cases may have their surgery delayed or canceled due to the potential complications associated with smoking. So that's a little bit about respiratory. Any questions?
No question.
Okay. No. All right. So cardiovascular status. Patient preparation for surgical intervention includes ensuring that the cardiovascular system can support the oxygen, fluid, and nutritional needs of the perioperative period. So we want to make sure that their heart is working well. Patients are assessed for cardiac comorbidities, including congestive heart failure, shortness of breath upon movement, and arrhythmias. Preoperatively, patients may receive a chest X-ray and an ECG to rule out any undiagnosed cardiac condition. Before surgery, the patient's baseline vital signs and blood pressure are taken. In elective situations, surgery may be postponed if there is evidence of cardiac decomposition or unexplained elevated blood pressure. Hepatic renal function. The pre-surgical goal is optimal function of the liver and urinary systems so that medications, anesthetic agents, body waste, and toxins are adequately metabolized and are removed from the body. So the liver is responsible for metabolizing medications, making sure that it's metabolized and then it's exported, to the whole body, that the medication has its effect. And then the kidneys are responsible for excreting all of that at the end. So we want to make sure that the liver and kidneys are both working well. Disorders of the liver may substantially affect how anesthetic agents are metabolized. So if they have acute liver disease, it is associated with high surgical mortality. The kidneys are involved in excreting anesthetic medications and their metabolites. Therefore, surgery is contraindicated if a patient has, acute nephritis, which is a kidney disease, acute renal insufficiency with oliguria. This means like a little bit of urine, and then anuria means little to no urine, or other acute renal problems. Okay. You also want to assess their endocrine function. Dysfunction of the endocrine system is associated with overproduction or underproduction of hormone or hormones. So just an example, a patient with diabetes who is undergoing surgery is at risk for both hypoglycemia and hyperglycemia. So frequent monitoring of blood glucose levels is important before, during, and after surgery. In regards to immune function, you always want to assess a patient before surgery just to make sure that there's no signs of an infection. They usually do blood work before surgery, so if there is an elevated white blood cell count, we would be a little bit concerned that they may have an infection. Surgery may be postponed in the presence of an infection or elevated temperature. And then also allergies and adverse reactions is important to identify and document any sensitivity to medication, solution, adhesives, and past adverse reactions. You also want to know about their previous medication use. So any medications the patient is using or has used in the past are documented. We went over this, but including over-the-counter preparations and herbal agents, as well as the frequency with which they are used. You also want to assess their psychosocial factors. Are they a highly anxious person? Because anxiety can trigger a physical response. It releases epinephrine and norepinephrine, which raises blood pressure, increases heart rate, cardiac output, and blood glucose levels. Therefore, overall healing may be impaired, while pain and risk of infection may increase post-operatively. And then you also want to assess their spiritual, cultural beliefs. Showing respect for a patient's cultural values and beliefs facilitates rapport, which means like a relationship with them, and trust. Knowledge of the patient's physiologic, psychosocial, cultural, spiritual, and educational needs allows the perioperative nurse to provide a holistic approach to care, which means like an individualized approach to care. All right, do you guys have any questions with any of these?
I had one question in regards to the hepatic and renal function. So if something happens with the liver, most of the time it's contraindicated and they can't do surgery.
Yeah, it depends on the extent. Like, if a liver, like say a patient has cirrhosis, I know you guys probably haven't learned about cirrhosis yet, but that's permanent scarring of the liver. So this patient has jaundice and that liver is like really not good at all. It can't like metabolize medications. So
Okay.
it can't really be able to like read those medications or really send it out to the body, you know?
Okay.
Yeah, so it just depends on the extent because some like if it's not permanently scarred, maybe they have a little bit of jaundice or things like that, or if they have something else wrong with the liver. But
Okay.
just depends. Any other questions?
No, that's the only question I had. Thank you.
You're welcome. Okay, so immediate preoperative nursing interventions. Patient changes into their gown, hair is covered, mouth inspected like we said, jewelry removed, valuables stored in a secure place. Then you're going to want to administer that pre-anesthetic medication. Remember that example I gave about that benzodiazepine, which is that medication that is a muscle relaxant, can help a patient fall asleep as well, and can help treat anxiety. So that's the nurse doing that. Maintaining a preoperative record, transporting patient to the pre-surgical area, and attending to family needs. Okay, so general preoperative nursing interventions. So providing psychosocial interventions, reducing anxiety, decreasing fear. So there is a couple cognitive coping strategies. So there's guided imagery, distraction, optimistic self-recitation, music therapy, aromatherapy, which means they like inhale aromatic oils to trigger emotional and physical relaxation relaxation responses through the olfactory system, which means the nose and brain. And then Reiki, the practitioner places hands over the patient to transfer energy to promote healing and relaxation. Those are a couple examples. Respecting cultural, spiritual, religious beliefs, maintaining patient safety, managing nutrition, fluids. We said this earlier, the purpose of withholding food and fluid before surgery is to prevent aspiration. We don't want any fluid or food in the lungs that can possibly cause pneumonia. Preparing the bowel. Some patients are given a cleansing enema or a laxative the evening before surgery and may be repeated the morning of surgery. The goals of this preparation is to allow visualization of the surgical site and to prevent trauma to the intestine or contamination of the peritoneum by fecal material. Yeah, fecal material is filled with bacteria, so it's always best to cleanse that patient. And then you also want to prepare the skin. So surgical site hair is removed. That should happen in the preoperative area. And then we also want to decrease bacteria without injuring the skin. So they do clean the skin sterilely. And then expected outcomes during this preoperative phase. Before surgery, we want the patient to be relieved of anxiety, decrease their fear. We want to make sure that they understand the surgical intervention. They have to sign those consent forms, and no evidence of preoperative complications. All right. Any questions on this chapter?
No.
Okay. Okay, so this is the intraoperative nursing management. The intraoperative phase begins when the patient is on the OR bed, and it ends when the patient is at the PACU, which is the post-anesthesia care unit. So the surgical team includes the patient, the anesthesiologist or the certified registered nurse anesthetist, the surgeon, nurses, surgical technicians, and registered nurse first assistants or certified surgical technologist. The patient fears can increase the amount of anesthetic medication needed, the level of postoperative pain, and overall recovery time. The patient will have a loss of sense of pain, reflexes, and the ability to communicate, subjects the intraoperative patient to possible injury. The OR nurse is a patient's advocate while surgery proceeds. So gerontological considerations. So the older adult patients are at higher risk for complications from anesthesia and surgery. So here are some of their risks. They include delirium, hypothermia, positioning injury, those pressure ulcers, a deep vein thrombosis, electrolyte imbalances, and circulatory compromise. A little bit about the surgical team and some of the nurses' roles in the OR. So the circulating nurse is a qualified registered nurse who works in collaboration with surgeons, anesthesia providers, and other healthcare providers. They manage the OR and protect the patient's safety and health by monitoring the activities of the surgical team, checking the OR conditions, and eventually assessing the patient for signs of injury and implementing appropriate interventions. So this nurse is basically circulating all around. They are, assessing the patient. They're making sure that the OR team is also doing the right thing. And they're also making sure that the OR is set and ready to go. The team is coordinated by the circulating nurse who ensures cleanliness, proper temperature, humidity, appropriate lighting, safe function of equipment, and the availability of supplies and materials. They monitor aseptic practices to avoid breaks in sterile technique while coordinating the movement of related personnel, as well as implementing fire safety precautions. The circulating nurse also monitors the patient and documents specific activities throughout the operation to ensure the patient's safety and well-being. Okay. So the circulating nurse basically does a lot. They're making sure that everything is going according to plan. The scrub role or the scrub nurse includes performing hand hygiene, setting up the sterile equipment, tables, and sterile field, preparing sutures, ligatures, and special equipment, and assisting the surgeon and the surgical assistants during the procedure by anticipating the instruments and supplies that will be required, such as sponges, drains, and other equipments. They're basically just making sure that all of the equipment is there, and then they're also assisting, handing it to the surgeon as well. As the surgical incision is closed, the scrub person and the circulating nurse count all needles, sponges, and instruments to be sure that they are accounted for and not retained as a foreign body in the patient. Yeah. The surgeon performs the surgical procedure, heads the surgical team, and is a licensed physician. The registered nurse first assistant practices under the direct supervision of the surgeon. They're handling tissue, providing exposure at the operative field, suturing and maintaining hemostasis. And then you have the anesthesiologist and CRNA, administers anesthetic agents, assesses the patient before surgery. And remember, like we said, they're going to talk to the patient before to make sure that they know what's going to happen in regards to the surgery and anesthesia. So they're going to select the anesthesia after talking to the patient. And then they're going to, when the patient's finally in the OR room, they're going to administer it. The patient may have to be intubated if necessary, and manages any technical problems related to the administration of the surgical agent, and supervises the patient's condition throughout the surgical procedure. The type of anesthetic agent to be given, previous reactions to anesthetic medications, and known abnormalities that would make airway management difficult are among topics addressed. When the patient arrives in the OR, the anesthesiologist or CRNA reassesses the patient's physical condition immediately prior to initiating anesthesia. So the anesthesiologist is going to monitor all these things: blood pressure, pulse, respirations, ECG, blood oxygen saturation level, tidal volume, blood gas levels, blood pH, alveolar gas concentrations, body temperature, and all those things, just to see how the patient is taking the anesthesia and how they're doing. Safety and infection prevention. So the EOR is a sterile environment, so there's many factors to prevent the spread of microorganisms that may cause surgical site infections. So the surgical environment is a restricted area where careful attention to infection prevention is at the highest standard. So hand scrubbing, machine and room cleaning, sterile supply and instrumentation use, and limited movement. Surgical attire. So there's specific zones and what you should be wearing in each zone. So the unrestricted zone is where street clothes are allowed. So that's like outside the OR. Then you have a semi-restricted zone where attire consists of scrub clothes and caps. And then the restricted zone where only scrub clothes, shoe covers, caps, and masks are worn. The surgeons and other surgical team members wear additional sterile clothing and protective devices during surgery. Masks are worn at all times in the restricted zone of the OR, and masks should fit tightly. Upper respiratory tract infections, sore throats, and skin infections in staff and patients are sources of pathogens and must be reported. So we need to know if an employee is sick. Okay, principles of surgical asepsis and sterile technique. Surgical asepsis prevents the contamination of surgical wounds. Sterile technique implies that the area is free of living microorganisms. The patient's natural skin flora or previously existing infection may cause post-operative infections. Rigorous adherence to the principles of sterility by OR personnel is basic to preventing infections. All surgical supplies, instruments, needles, sutures, may come in contact with surgical wound or exposed tissues must be sterilized before use. The surgeon, surgical assistants, scrub personnel, and nurses prepare themselves by scrubbing their hands and arms with antiseptic soap and water, alcohol-based product. So basically the whole idea is to be as sterile as possible. Environmental controls. So there is an air pressure in the OR room. Standard OR ventilation provides 15 air exchanges per hour. Any questions before we get into anesthesia?
No.
Okay. So the surgical experience. During the surgical procedure, the patient will need sedation, anesthesia, or a combination of these. There are many low-risk anesthesia agents to choose from. Types, and these are the different types. So there are, I believe, 5 types. Yeah, I try to color coordinate just to make it easier for you to review. So under general anesthesia is going to be inhalation and IV. Under here, regional would be epidural and spinal, and then so on. Okay, so general anesthesia. So anesthesia is a state of narcosis. So it causes severe central nervous system depression produced by a pharmacological agent. It also produces analgesia, which means the patient is not going to feel any pain at all. It also helps the patient relax, and the patient will not have any reflexes. So they cross the blood-brain barrier and it affects the central nervous system. Patients with general anesthesia lose the ability to maintain ventilatory function and require assistance in maintaining a patent airway. So with this one, you're going to see some type of ventilation and oxygen used on this patient. Cardiovascular function may be impaired as well. The responses of the pupils, blood pressure, and the respiratory and cardiac rates are among the most reliable guides to the patient's condition. So like we said, that anesthesiologist is going to be monitoring blood pressure, pupils, respiratory function, all things like that, just to see how the patient's doing and how the patient is handling the anesthesia. Relatively large amounts of anesthetic medication must be given during induction and early maintenance phases. When possible, the anesthesia initiation begins with IV anesthesia and is then maintained at the desired stage by inhalation methods, achieving a smooth transition and eliminating the obvious stages of anesthesia. All are given in combination with oxygen and usually nitrous oxide as well. So with general anesthesia, this patient will be getting oxygen. Any questions? Okay.
No.
All right. So inhalation is a part of general anesthesia. So this is a gas anesthetic agent given by inhalation and are always combined with oxygen. So when inhaled, the anesthetic agents enter the blood through the pulmonary capillaries and act on the brain centers to produce a loss of consciousness and sensation. When anesthetic administration is discontinued, the vapor gas is eliminated through the lungs. So this one is pretty simple. It's going to enter through the lungs, and then when the surgery is over and anesthesia is discontinued, it's going to exit throughout the lungs. All right. Intravenous administration of general anesthesia. IV administration of various anesthetic and analgesic agents such as a barbiturate or a benzodiazepine, which I talked about a little bit earlier. That benzodiazepine, which can be given via an IV. These medications may be given to induce or maintain anesthesia. An advantage of an IV anesthesia is that the onset of anesthesia is pleasant. There is no buzzing, roaring, or dizziness known to follow administration of an inhalation anesthetic agent. So that's a little difference between the inhalation method and the intravenous method. So with inhalation, they might have buzzing or roaring or dizziness, but with IV, they're not going to have that, most likely not. The duration of action is brief and the patient awakens with little nausea or vomiting. The IV anesthetic agents are non-explosive, require little equipment, and are easy to administer. IV anesthesia is useful for short procedures, but is used less often for the longer procedures of abdominal surgery. So if a patient's having abdominal surgery, they most likely will go with inhalation method since it's longer. The combination of IV and inhaled anesthetic agents produces an effective and smooth experience for the patient with a controlled emergence following surgery. IV neuromuscular blockers, muscle relaxants block the transmission of nerve impulses at the neuromuscular junction of skeletal muscles. All right. Any questions on general anesthesia? Okay. Multimodal anesthesia. Multimodal analgesia regimens in surgical patients often use a combination of scheduled non-opioid analgesic agents and regional anesthesia techniques. So they're trying not to use an opioid. Multimodal analgesia aims to reduce opioid requirements and associated risks such as sedation, respiratory depression, nausea and vomiting, and potential of overuse of opioids. So that's the whole idea between a multimodal anesthesia is that they don't want to use opioids because of the signs and symptoms of respiratory depression and things like that that can go wrong. Multimodal anesthesia is a growing trend. in the enhanced recovery after surgery, as it decreases the risk of general anesthesia and aids in opioid reduction strategies. Okay. Regional anesthesia, an anesthetic agent is injected around nerves so that the region supplied by these nerves is anesthetized. The effect depends on the type of nerve involved. An anesthetic agent is not considered metabolized until all three systems, motor, sensory, and autonomic, are no longer affected. The patient receiving regional anesthesia is awake and aware of their surroundings, unless medications are given to produce mild sedation or to relieve anxiety. So regional, this patient is awake and can be aware of what's going on. So an example of this is such as epidural anesthesia. We know that a lot of women going into labor are given an epidural. So an epidural anesthesia is achieved by injecting a local anesthetic agent into the epidural space that surrounds the dura mater of the spinal cord. It provides anesthesia and pain relief. In contrast, spinal anesthesia involves injection through the dura mater into the subarachnoid space surrounding the spinal cord. Epidural anesthesia blocks sensory, motor, and autonomic functions. It differs from spinal anesthesia by the site of the injection and the amount of anesthetic agent used. Epidural doses are much higher because the epidural anesthetic agent does not make direct contact with the spinal cord or nerve roots. And I highlighted this because I remember that this was really important last year. So an advantage of epidural anesthesia is the absence of a headache that can result from spinal anesthesia. So that's a little difference between an epidural anesthesia versus a spinal anesthesia. A disadvantage is the greater technical challenge of introducing the anesthetic agent into the epidural space rather than the subarachnoid space. It's just more difficult for the person doing the epidural to get it there, so it is difficult. If inadvertent puncture of the dura occurs during epidural anesthesia and the anesthetic agent travels toward the head, high spinal anesthesia can result. This can produce severe hypotension and respiratory depression and arrest. Treatment of these complications include airway support, IV fluids, and the use of vasopressors. My labor and delivery teacher sort of gave me an example of this last semester. So she said that she had a patient where they were giving a doctor was given a epidural medication and they missed and it traveled somewhere else, and then the patient had respiratory depression. So they had to intubate her for like 3 hours because she couldn't breathe on her own. But eventually the medication does wear off. So then eventually they got her back and then she could eventually breathe on her own. But they had to ventilate her for a couple of hours. Any questions with epidural anesthesia? Okay. So spinal anesthesia is an extensive conduction nerve block that is produced when a local anesthetic agent is introduced into the subarachnoid space at the lumbar level, usually between L4 and L5. It produces anesthesia of the lower extremities, so the perineum and the lower abdomen. A few minutes after induction of a spinal anesthetic agent, anesthesia and paralysis affect the toes and perineum, and then gradually the legs and abdomen. Like I said, headache may be an after effect of spinal anesthesia. So several factors are related to the incidence of headache. The size of the needle, the leakage of fluid from the subarachnoid space through the puncture site, and the patient's hydration status. And the ways to help the headache, a quiet environment, because this patient is awake during a spinal anesthesia. Keeping the patient lying flat and keeping the patient well hydrated. Next is peripheral nerve blocks. So peripheral nerve blocks are used in conjunction with general, or we're going to talk about this a little bit later, MAC anesthesia, or as a standalone method. Instead of a single nerve being targeted, a bundle of nerves is located via ultrasound and injected with an anesthetic, opioid, or steroid. So An example of a peripheral nerve block, when I had my externship in the summer, a patient, they couldn't find an IV in her arm, her lower arm, so they had to do one, her upper arm. So they had to get my registered nurse who's like a pro at doing peripheral nerve blocks. So he brought in the ultrasound and he found the bundle of nerves and then he inserted it with a long needle. So instead of a single nerve being targeted, a bundle of nerves is located. So patients emerge from anesthesia with less pain, decreasing the need for opioids. Examples of common local conduction blocks include a brachial plexus block, which produces anesthesia of the arm. That's the one that I saw. A paravertebral anesthesia, which produces anesthesia of the nerves supplying the chest, abdominal wall, and extremities. Transsacral caudal block, which produces anesthesia of the perineum and occasionally the lower abdomen. So the main thing to remember with this one is that it does completely numb an area for a patient where they don't feel anything, but this patient is completely awake the whole time. All right. Next is moderate sedation. So moderate sedation, previously referred to as conscious sedation, is a form of anesthesia that involves the IV administration of sedatives or analgesic medications to reduce patient anxiety and control pain during diagnostic or therapeutic procedures. Commonly used for many short-term surgical procedures. With moderate sedation, the patient is able to maintain a patent airway, retain protective airway reflexes, and respond to verbal and physical stimuli. The continual assessment of again, like this goes for all, and the continual assessment of the patient's vital signs, level of consciousness, and cardiac and respiratory function is an essential component of moderate sedation. Also want to pay attention to the pulse ox, a continuous ECG monitor, and frequent measurement of vital signs are used to monitor the patient. Monitored anesthesia care. MAC may be used for healthy patients undergoing relatively minor surgical procedures and for some critically ill patients who may be unable to tolerate anesthesia. And then you also have local anesthesia, is the injection of a solution containing the anesthetic agent into the tissues of the planned incision site. So this one is the tissues. Often it is combined with a local regional block by injecting around the nerves, immediately supplying the area. So tissues, and it can be also with that local regional block as well. And these are some local anesthetic system toxicity, potentially life-threatening event, rapidly absorbed into the systemic circulation, resulting in cardiovascular or neurologic collapse. Signs and symptoms of last are metallic taste, oral numbness, auditory changes, slurred speech, arrhythmias, seizure, and respiratory arrest. Any questions on any of these 5 anesthesias? Okay. So potential intraoperative complications, anesthesia awareness. Only general anesthesia is meant to create a state of oblivion. All the other 4 forms of anesthesia will eliminate pain, but the sensation of pushing and pulling tissues during surgery may still be recognized, and they may hear conversations among the operative team. In many cases, patients may be able to respond to questions and involve themselves in the discussion. So this is normal and is now referred to as anesthesia awareness. So anesthesia awareness is when a patient is awake during general anesthesia. A patient should never be awake during general anesthesia, or they should never be aware during general anesthesia. They shouldn't be moving or having any reflexes or shouldn't be awake at all. So some signs if they're awake or like mildly awake would be, an increase in blood pressure, rapid heart rate, the patient's moving. However, hemodynamic changes can be masked by a paralytic medication. So if a patient's on a beta blocker or calcium channel blockers. So those 2 medications, those are used for hypertension. And if patients have like really high heart rates, they're usually given those medications to lower it a little bit. So it can be masked. If those patients are on medications that are in a lower blood pressure, low heart rate, you can't really notice that they are awake because the medication is masking it. All right. Any questions? Okay. A little bit about nausea and vomiting. Nausea and vomiting may affect patients during the intraoperative period. The patient should be assessed preoperatively for risk factors of postoperative nausea and vomiting so that the surgical team can formulate a plan for intraoperative prevention. Nursing interventions. If gagging occurs, the patient is turned to the side, the head of the table is lowered, and a basin is provided to collect the vomit. Suction is used to remove saliva and vomited gastric contents. If the patient aspirates vomit, an attack with severe bronchial spasms and wheezing is triggered. Like I said before, nausea and vomiting can have serious complications, such as aspiration and the patient developing pneumonia, as well as pulmonary edema, which is fluid in the lungs. And both those things can lead to hypoxia, where they can't breathe and there's no oxygen. So it can be really serious if nausea and vomiting occurs. So that's something you want to pay attention to if you're become a intraoperative nurse. Anaphylaxis refers to allergies. This can occur in response to many medications, latex, or other substances. The reaction may be immediate or delayed. Anaphylaxis can be life-threatening as well. So a latex allergy, the sensitivity to a natural rubber latex products has become more prevalent, creating the need for alert responsiveness among healthcare professionals. Nurses must be alert to the possibility and observe the patient for changes in vital signs and symptoms of anaphylaxis when these products are used. In the OR, the team should remove potential causative agents promptly within 3 minutes or less of becoming aware of an anaphylactic reaction, so prompt intervention to prevent cardiovascular and respiratory collapse. A little bit about hypoxia and other respiratory complications. Inadequate ventilation, occlusion of the airway, inadvertent intubation of the esophagus, and hypoxia are significant potential complications associated with general anesthesia. Causes may include respiratory depression caused by anesthetic agents, aspiration of respiratory tract secretions or vomit, the patient's position on the table. So all these things can contribute to a patient not having proper oxygenation. Brain damage from hypoxia occurs within minutes. Therefore, vigilant monitoring of the patient's oxygenation status is a primary function of the anesthesiologist or CRNA and the circulating nurse. Peripheral perfusion is checked frequently. Hypothermia. During anesthesia, the patient's temperature may fall 36.6 or less. Some causes if they become like really cold, so there's usually a low temperature in the OR. Maybe the patient is given infusion of cold fluids, inhalation of cold gases, open body wound or cavities, decreased muscle activity, or they're older adults, or the pharmaceutical agents used, depending on certain medications. Malignant hyperthermia is rare inherited muscle disorder that's chemically induced by anesthetic agents. So it's induced by certain medications. This disorder can be triggered by emotional stress, heat stroke, NMS, which you'll learn in psych, so don't pay too much attention to that. Strenuous exercise exertion and trauma. Any questions with intraoperative? Okay. Yeah. Okay. Chapter 16, it goes over post-operative nursing management. So during the post-operative phase after surgery, nursing care focuses on reestablishing the patient's physiological equilibrium, alleviating pain, preventing complications, and then educating the patient about self-care before they leave. So careful assessment and immediate intervention assist the patient in returning to optimal function quickly, safely, and as comfortable as possible. So in this phase, we just want to make sure that they get back to baseline after anesthesia and, recovery after surgery. Care of the patient in the post-anesthesia care unit. Patients still under anesthesia or recovering from anesthesia are placed in this unit. Most nurses love this unit because it's, most nurses say it's like pretty relaxing because most patients are recovering. Yeah, I always hear good things about that unit. Phases of post-anesthesia care. So there's a phase 1 PACU is used during the immediate recovery phase. Intensive nursing care is provided. After this phase, the patient transitions to the next phase of care as either an inpatient to a nursing unit or phase 2 PACU. In this phase 2 PACU, the patient is prepared for transfer to an inpatient nursing unit, an extended care setting, or discharge. So there's 2 units. Admitting the unit to the PACU. Transporting the patient involves special consideration of the incision site, potential vascular changes, and exposure. So the surgical incision is considered every time the postoperative patient is moved. When you're moving that patient, oxygen is applied, monitoring equipment is attached, and an immediate physiologic assessment is conducted. Nursing management in the post-anesthesia care unit. The nursing management objectives for the patient in the PACU are to provide care until the patient has recovered from the effects of anesthesia. Recovery criteria include a return to baseline cognitive function. You want to make sure that that airway is clear, nausea and vomiting is controlled. Again, we don't want that patient to aspirate or get any fluid or food in the lungs. And we want to make sure vital signs are stabilized. A nurse in the PACU, you need to make sure and detect early subtle changes that could lead to complications, such as hemorrhage if a patient's like bleeding extensively, or if there's any type of respiratory distress. Is that you need to detect that. So assessing the patient. The nurse performs frequent basic assessments of every postoperative patient. These assessments include airway, level of consciousness, cardiac, respiratory, wound, and pain. Vital signs are assessed at a time of arrival to PACU and then repeated at intervals. Usually they're repeated at different intervals depending on the hospital you're at. So maintaining a patent airway. The primary objective in the immediate postoperative period is to maintain ventilation and thus prevent hypoxemia, which means reduced oxygen in the blood, and hypercapnia, which means excess carbon dioxide in the blood. Both can occur if the airway is obstructed and ventilation is reduced. Besides administering supplemental oxygen as prescribed, the nurse assesses respiratory rate and depth, ease of respirations, oxygen saturation, and breath sounds. So you're assessing all things respiratory and trying to avoid anything. So this is just saying you just want to prevent anything where there's low oxygen. And here are some signs of occlusion, choking, noisy and irregular respirations. Maybe the respiratory rate is super high, decreased oxygen saturation, and within minutes, a blue dusky color. Maybe they're cyanotic. Okay. Maintaining cardiovascular stability. To monitor cardiovascular stability, the nurse assesses the patient's level of consciousness, vital signs, cardiac rhythm, skin temperature, color, and moisture and urine output. The nurse also assesses the patency of all IV lines. The primary cardiovascular complications seen in the PACU include hypotension and shock, hemorrhage, hypertension, and arrhythmias. So a little bit about hypotension and shock. You guys probably didn't get up to shock yet in your chapters, but a little bit about it. So hypotension can result from blood loss, hypoventilation, position changes, pooling of blood in the extremities, or side effects of medications and anesthetics. So when a patient is hypotensive and they are like extremely hypotensive, you may want to put them in the Trendelenburg position. So they're flat, legs are elevated, usually with a pillow. and that can help with that. This position helps increase the blood pressure. The most common type of shock in the postoperative setting is hypovolemic shock. Hypovolemic shock is low fluids in the body, so maybe they lost a lot of blood and now they're like, so normal units of blood in the body includes 5 liters. So say they lost like 1 liter, now they have 4 liters, you would be concerned. And the patient would probably present with hypotension if they have hypovolemia, which you're going to learn with the electrolyte chapter. So don't pay too much attention to that. A little bit about hemorrhage. That's when the patient is basically bleeding a lot. So hemorrhage is an uncommon yet serious complication of surgery that can result in hypovolemic shock and death. So signs and symptoms of a hemorrhage, so they're bleeding out a lot, includes hypotension, a rapid thready pulse, disorientation, restlessness, oliguria, which means a little bit of urine, and cold, pale skin. Laboratory values may show a sharp drop in hemoglobin and hematocrit levels. So your hemoglobin in the blood measures your red blood cells, which red blood cells are your oxygenated blood cells, and your hematocrit levels. So if you see a sharp drop in your red blood cells, you would want to be concerned for a hemorrhage. Determining the cause of hemorrhage includes you want to assess the surgical site that was just performed and that incision for bleeding. If bleeding is evident, as the nurse, a sterile gauze pad and pressure dressings are applied, and the site of bleeding is elevated to heart level if possible. Patients with a blood loss over 1,500 milliliters should be considered for blood administration. And right here, that's 1.5 liters. So normal, the amount of liters a normal person would have is 5 liters. So if they're bleeding like an excessive amount, like 1.5 liters, you would be concerned. Hypertension and arrhythmias. Hypertension is common in the immediate postoperative period, secondary to sympathetic nervous system stimulation from pain, hypoxia, or bladder distension. Arrhythmias are associated with electrolyte imbalances, altered respiratory function, pain, hypothermia, stress, and anesthetic agents. Relieving pain and anxiety. So opioid analgesic medications are given mostly by IV in the PACU. IV opioids provide immediate pain relief and are short-acting. The nurse should consider providing non-pharmacological, emotional, and psychological support to the patient. And these are some of the examples. We talked a little bit about this before. So massage, acupuncture, heat or cold packs, relaxation and breathing techniques, guided imagery. You tell them about like a nice, happy memory, and soothing music. Controlling nausea and vomiting. So post-operative nausea and vomiting is controlled via medication administered intraoperatively and post-operatively. These medications are known as antiemetics. And you need to prevent aspiration to prevent pneumonia, like I said. Gerontological considerations. Nurses should keep in mind that older adults may have slower recovery from anesthesia due to the prolonged time it takes to eliminate sedatives and anesthetic agents. So they might have that anesthesia in them a little bit longer. So you want to keep watch of them because they could be at fall risk coming out of that. Postoperative confusion delirium may occur in up to half of all older adult patients. Hypoxia can present as confusion and restlessness, as can blood loss and electrolyte imbalances. Exclusion of all other causes of confusion must precede the assumption that confusion is related to age, circumstances, and medications. So you can't just assume that they're confused because they're aged. You just want to investigate a little bit, make sure that they're breathing fine, that their oxygen saturation is normal, that there's no hypoxia or anything like that. Bariatric considerations. So patients with obesity have unique post-operative risk, including an increased risk of venous thromboembolism, vein thrombosis, pulmonary embolus, those clots. Patients with obesity are at particular risk for obstructive sleep apnea, which means they don't breathe when they're sleeping. So you want to pay attention to that as well. Determining readiness for post-anesthesia care unit discharge. A patient remains in the PACU until fully recovered from the anesthetic agent. So indicators of recovery include that their blood pressure is stable, adequate respiratory function, they can breathe well, and adequate oxygen saturation level compared with the baseline. Just want to make sure all those things are good. And then preparing the postoperative patient for direct discharge. So you want to follow up on phone calls from the nurse or assess the patient's progress and answer any questions. So the patient gets discharged, but calling them about making sure everything's going well with them is important as well. All right, and I think that's all. Does anyone have any questions?
I have a question.
Yes.
So, for the circulating nurse, do you need a special qualification to be a circulating nurse?
I believe just a registered nurse. Yeah.
Okay.
Any other questions?
No.
Okay, well, that was everything for perioperative nursing. If you guys need help with anything else, you can just let me know. All right.